Okay, great. So welcome to Project Echo Dementia for Friday, April 11th. I'm Chris Rhoads, a neuropsychologist and co-lead of this wonderful project. And we have an excellent session today. We've got a couple more people in the waiting room. Excellent. So we'll do our usual format of some opening notes and reminders. If it is your first time with us, feel free to throw your name, maybe your role and your location into the chat. That would be great. And then we have the excellent good fortune of having our own Dr. Domoto-Reilly doing our didactic and case vignettes around establishing a direct clinical law enforcement partnership to address dementia crisis intervention across Washington State, which is a project that I have the honor of being involved in, along with Shamey, and graciously funded by the Garvey Institute here at the University of Washington. So promises to be an excellent and very relevant didactic. So a couple reminders. If looks like everyone is accurately named that's here currently. We know who Lynn is for other name there. Everyone looks like they're also muted with not speaking and practicing saying your name and unmuting when you unmute. If you're able to, having your video on is always lovely as we get to know our community a little bit better here, but also understand that that's not always a possibility. And it's rare these days, but if there's more than one of you in your location, just adding names into the chat so we can keep track of who's here for CME and other purposes. Speaking of which, here's the process. If you are a University of Washington affiliate, faculty, staff, or student, texting your email address to that number and then the code 10085. I get about an hour either side of the activity to claim CME. And everybody else, we will keep track through our usual protocols via Zoom. Just some reminders, we like to cross-promote other educational opportunities, including Echo Geriatrics, which is a fantastic long-running Echo series, TBI, psychiatry and addictions. There's consultation opportunities too, so no shortage of resources through the University of Washington, around the state of Washington. And then repositories of information through Grand Rounds archives, all that good stuff. I also want to be sure to promote next week's Healthy Aging Summit, put on by Providence Swedish, and featuring our own Mary Grace Becker from the University of Washington, amongst others. And many thanks to Dr. Eisenberg and Swedish for putting this on. I believe it's the outstanding price of free for attendees, so can't do much better than that. Cases, absolutely a critical part of our learnings here, and we continue to think about ways to make the lift as light as possible, and we'd love your suggestions if you have any. But here's kind of the contact information for that process. We don't have a formal case today, but looking forward to a very clinically relevant discussion after the didactic and doing our best to protect PHI. We are recording today, and we'll have this up on our website for your viewing pleasure at a later time if needed. Of course, there's always the 1-minute post-session survey. We're accredited for 1.25 credits. Dr. Domoto-Reilly graciously disclosed that she receives Speakers Bureau compensation from an organization that was mitigated to not have any relevance to today's discussion, but thank you for being open and transparent about that. Here's our hub team. Here are our community members who have participated over time. We're so close to announcing this expansion project, but I'm going to hold off on that. But we will be actively looking for FQHCs and rural clinics to partner with Echo and Cognition and Primary Care, which is led by our own Dr. Gaster. And we'll look forward to telling you more about that in an upcoming session. So stay tuned. We already talked about that. And with that, it is my absolute pleasure to turn it over to my colleague, Dr. Domoto-Reilly, outstanding neurologist here at Memory and Brain Wellness, who will talk about our work partnering with law enforcement around the state of Washington. And I want to just one last thing I want to share here is that this work really comes out of the connection with the Dementia Action Collaborative, with our initial partners who presented quite some time ago. So it's nice to see this connecting with another thing that's come out of the Dementia Action Collaborative, which is ECHO. So, all right, I'm going to stop there and turn it over to you.
All right, well, thank you so much for the opportunity to speak with you today about this project. Um, um, again, just thrilled to have this opportunity, really hoping for feedback from all of you about this partnership that we've created. And yes, as Dr. Rhoads mentioned, I am presenting on behalf of our team, working together with Dr. Rhoads and with Samantha, and also had help from a medical student, Shamey, with doing some of our data crunching. And this work would not have been possible without the direct partnership with the Tumwater Police Department and also the Washougal Police Department. And as mentioned, I do have a financial disclosure, but it is not relevant to the content of this talk. So I'll give you an overview of this project, the progress to date, results of surveys, and sort of semi-structured interviews that we have performed, where we're going to this year, and really hoping to elicit some discussion and feedback from all of you. And I hope that many of you had been able to attend the March 14th presentation by Karen Hayes, our community member who has so much personal experience with some of these difficult issues that can come up in being a caregiver for someone with dementia. And if you missed it, or if you want to watch it again, it is currently posted. But really, this presentation builds upon what she presented last month. And also very much want to thank our sponsors. The Garvey Institute for Brain Health Solutions here at University of Washington was founded very generously to improve the health of people in Washington state and beyond. They put out calls each year for grants, and what caught my eye back in 2023 was the opportunity in 2024 to create innovative partnerships to extend the impact of mental health professionals in Washington state. And there was a call for help with partnering with law enforcement professionals to improve the care of individuals experiencing a mental health or addiction crisis, and really to focus on services before detainment so that people who are in crisis are not brought to jail unnecessarily. And so this seemed like a good opportunity, and fortunately we received funding. So this project, Clinical and Law Enforcement Partnerships to Address Dementia Crises, was to meet with clinicians, members of law enforcement, and also community stakeholders so that we could identify dementia crises which might require law enforcement involvement, to identify gaps, but also resources that already exist in the community. So in 2024, we conducted various interviews, speaking with clinicians, also with law enforcement and community stakeholders about their experiences, and to see, where is further help needed. We also set out to find what are existing resources that are already working well. And ultimately, we wanted to identify 3 crisis response priorities to develop a safety packet. And so this is just an overview of what we worked on in 2024. Of course, with this being research and with potentially sensitive interviews, we worked with our institutional review board. We created these interviews and surveys. We also requested call center logs from 911 from each of these communities to get a better sense of when the public feels compelled to call 911 with their concerns. And then reviewed these different data sets, and then have done some reporting back to the community. We were fortunate to get our funding extended for another year. And so we are continuing our interviews with community members. And while we've received a lot of valuable input, at the moment, we're not focusing this presentation on that input because we're still in the information gathering phase. And we'd also like to present to you a draft of the safety packet for your input. So again, mentioning here that we conducted surveys and also semi-structured interviews. And also you've heard from, for example, a community stakeholder, Karen Hayes, last month, and we'll be collecting more data going forward. So for the clinician survey within the Memory and Brain Wellness Center clinic, we have a multidisciplinary center. So we have neurologists, psychiatrists, neuropsychologists, geriatricians, and social work. So lots of different people who help us with our care for people with dementia. We created a survey for people to fill out, but then also conducted group and individual interviews. So much of our results are really the conversation that came about because of the survey results. And as we were collating the information for this talk, we realized, it seemed like more people had filled out the surveys, but we didn't have access to that data. So with that caveat, what we asked specifically about in the surveys were how often, to get a sense of the frequency and severity of potentially summoning 911 or interacting with law enforcement. So how often do you hear about someone, one of the patients in the clinic, being involved with wandering, trespassing, shoplifting, threatening behavior, financial abuse or fraud, firearm safety, or if there are other incidents that come to mind. And then with each of these incidents, how severe were they? And so with the small number of surveys that we have captured, for wandering, that did seem to come up fairly often, was not always a very severe issue, but certainly had some level of frequency. For trespassing, it didn't seem to come up very often, but when it happened, it was more severe. Shoplifting did not come up very often, but did involve law enforcement, somewhat severe. And then, unfortunately, again, as you heard from Karen Hayes, this threatening behavior can become a severe issue and can come up somewhat frequently. Financial abuse and fraud did sometimes come to the attention of our clinicians, and when it did, it was often quite severe. And then firearm safety sometimes came up and ranged likely from people asking, how can I safely remove a firearm from the home to actually quite devastating consequences. In terms of other instances which might involve law enforcement, there were safety checks, episodes of acute mania, concerns for self-neglect, paranoia, disrobing, hoarding, and also welfare checks. And again, when they came to the to the clinicians' knowledge, they were often quite severe. Then in our semi-structured interviews, we were asking also for feedback from clinicians for when we then went to visit police departments. What is feedback or questions that we should ask of law enforcement, and what are feedback or questions that we should ask of community stakeholders? And many clinicians expressed a desire to appropriately prepare families for potential outcomes of a crisis situation. So, for example, that when there is a call, a distress call, that sometimes a request to remove someone from the home, that may or may not happen. Another bit of feedback was that in a time of crisis, even with preparation, it can be hard for a caregiver to stay calm. And so it can be helpful for a 911 dispatcher or law enforcement when they are on the scene, or both, to model de-escalating behaviors, just to remind everybody that trying to stay calm can help the person in crisis. And then also, there was feedback that a desire for law enforcement to know that if they arrive and everything seems to be okay, it can be very helpful for the person who summoned them to hear that, we're glad everything is okay now, but please do not hesitate to call us again, even if it's as we're exiting 5 minutes later, that if you feel unsafe, it is okay to call again. And again, if anybody has questions or comments, please feel free to jump in. So then, again, we had the opportunity, we were very, very fortunate to work with police in Tumwater and also in Washougal. And we paid each of these departments a few visits and ultimately obtained 28 surveys. Through conversation with the law enforcement officers, we were also directed to speak with 911 dispatch. And so had the opportunity to speak with them as well. And what was interesting is the folks we talked with, they ranged from recent graduates from the police academy to decades of experience. And so it was really interesting hearing from this broad range. We even spoke with basically everybody on the team, including animal control. So it really is a team effort and close collaboration and communication. And so from law enforcement standpoint, they did report that sometimes concerns for wandering led to them being involved, and that sometimes it could be severe, but not always. Trespassing did sometimes come up as a reason that law enforcement was summoned, and there was some level of severity for trespassing. Shoplifting for some people had never come up, but sometimes it would, and there was sort of a slight severity there. And then sometimes there were reports of threatening behavior, concerns for violence, which could be severe. Financial abuse or fraud sometimes came up and sometimes was quite memorable in the degree of severity. And similarly, actually, rarely firearm safety came up, but sometimes it was, again, quite a tragic circumstance. And other instances that our law enforcement partners mentioned that they became involved with, and also they say, sometimes we are just patrolling, and so since they're out in the community, they may be just hailed down. People ask for help, and it turns out that the person of concern has cognitive impairment, so they help out with medical assistance, assistance with activities of daily living, car accidents, assisted living facilities, the staff summons help, general confusion. Sometimes there are repeated 911 calls, and sometimes this is on behalf of the person with memory loss. Family members sometimes are fearful, either for their safety of people, or family members can also become concerned about welfare or unable to contact the person that they're worried about. So again, a range of other instances, and up to a level of moderate severity. So from Washougal, from their interviews, there was the feedback was that police officers really wanted clinicians and the general public to understand how they can help, but also, again, setting expectations that there are limits of what they can do in certain situations, and they want to help protect people's individual rights. There were discussions about capacity, also how to de-escalate a situation, and again, even having family members or staff members at a facility understand that charges is not always appropriate to press charges, and it's also not always appropriate for somebody to be removed from where they are living in that moment. Again, there was concern for wandering, concern for violence against caregivers. And there also was a lot of discussion about how closely tied and invested they are in their communities. So this community-based policing, really wanting to know who they are caring for, who they are providing safety for, really being wanting to be proactive and helping people stay safe, and being collaborative with the members of their community, so that there's open communication and understanding. There was knowledge about crisis services, but sometimes there were limits in terms of when, what time of day these services would be available. With the Tumwater Police Department, again, similar that they need to protect people's individual rights. Also thinking about de-escalation, preventing trauma, concerns about wandering and violence about caregivers, calls from adult family homes, and an interest in the moment providing resources for people in crisis to hopefully reduce further events. So these different police departments, they have resource walls. If somebody comes to the police department looking for ways to improve home safety, they can hold on to pamphlets there. For example, some of these departments, they carry things on their person. I mean, they carry so many things around, and there was a desire to have a pamphlet that they could just hand out immediately. And then sometimes the patrol cars are equipped with printers, so they can just step out and print out an appropriate pamphlet so that the person can then place a call for appropriate help. So then we were directed to the 911 call centers, that really they're sort of the linchpin when somebody is perceived to be in such a crisis that 911 is called. The dispatchers are the ones who are interacting with the person summoning help, and then also providing ongoing information to the responding officers. So we visited a call center, and you just see that they have all these different screens and different ways that they are trying to gather information and figure out what they should be providing to who's being dispatched. So there's multiple internal and external databases. There is some historical information. If there's a call from a certain residence, they can sort of look back at past calls and try to get more of a sense of what the call could be about and how to help appropriately. There was a lot of talk about this service. One company that does it is called Smart 911, where it's an external database that the general public can provide their own information to. And the dispatchers really like it because then there are prompts to keep it updated, and this is from the community members themselves, and that they can have access to as the call is in process. So like for a 30-minute time window, they have access to the information that is provided about a certain residence. They also wanted to make sure we knew about that there are specific protocols that they have to follow. Is it going to be fire that goes out? Is it going to be medical? Is it going to be police? Is it going to be multiple people that get sent out? There are standardized questions that they have to go through each time. And that it's really obviously the current situation that the questions that they ask, they determine what happens in that incident. Because there could have been a fire before, but now there's a call for medical help. So that it's really at that time determining what is required. So yeah, some of the feedback, police officers were, especially related to wandering, they were hoping that families could be aware of the existence of GPS trackers. That a lot of families say, well, so-and-so always brings a cell phone when he goes on a walk. But they say, well, for us to track the cell phone, we need to know the phone number and also, what service. Is it AT&T? Is it, they need to have that information in order to activate tracking on that person's phone. And they did say it is helpful for them to know if somebody in a home has memory loss. And this also could pertain to any circumstance in which 911 is called. For example, if there is a need to evacuate because of an earthquake, it's helpful to know who within a home may need additional assistance. And they like to have that information. It's not a burden to them to be given that information. A theme that also came up is that sometimes they are called when there are the usual caregiver or family member goes away and there's a different caregiver that comes in. And there's a little disruption to the routine. And so the person with memory loss is not where they're expected to be. And so the caregiver that has stepped in calls 911, but may not know all the basic information that the 911 dispatchers would be asking for. Even, for example, where are you right now? Not everybody knows an exact address or phone number. So a recommendation that if there are going to be other people helping out, that having this basic information, whether or not somebody has dementia, potentially what medicines they're on, but again, what are their typical habits? All of this is readily available to anyone who might feel a need to call 911 from that residence. Additional information that can help with de-escalation and also for finding people if they're not at home. Descriptions of a person's routines, or do they have a walker? How far is somebody expected to get? Do they have access to buses? If they were to have to help to look for someone, where might they be found? Do they like to go to the local grocery store? Also, they like to hear tips about how to de-escalate a situation or promote, good reactions. Is there a nickname that they should use when they're approaching the person? Or are there topics they should avoid or approaches that they should avoid? So again, the police, when they are summoned, like to hear all of this information to have the best outcome possible. So with all this information, we are now working towards developing a safety packet. And the top safety priorities that we are working on are wandering, threatening behavior, and financial abuse or fraud. And for additional concerns, we're thinking about having inserts like for firearm safety or specific local resources such as the Whatcom County Project Lifesaver. And then also where we're hoping for input from you is where should these safety packets live? Where would they be ideally distributed? So certainly they can be available in clinics, and those would be for people who have then a diagnosis of dementia or memory loss. But that police stations and officers, even for people who have not yet received a formal diagnosis, in a time of crisis could distribute these safety packets. There was an idea that perhaps it would be useful to have them in emergency rooms, and certainly with our community partners, making them available through community events as well. So we have two sides that we would love to have your feedback on. And again, this was based on input from our officers, that having a physical pamphlet would be the most helpful. We could at some point include a QR code, but for the communities we spoke with, it really seemed like having a phone number to call for next steps and help would be the most helpful. And so we're also working with our partners to adjust the details here, but information about the Alzheimer's Association, highlighting here, thinking ahead, being prepared, hopefully avoiding these crises, but thinking about risks of wandering, threatening behavior, financial abuse, and tied closely to wandering is driving risks. And then on the other side, featuring this Smart 911. Also that in the moment, if somebody is feeling quite threatened, the instructions that if somebody doesn't feel comfortable saying, I'm calling because my loved one has dementia, they could cue the dispatcher to say, please check Smart 911. Just a reminder that there could be additional information in that other database. And any and all information as minimal as the person would like, or as expansive as they would like. If sometimes to have a code to get into the home instead of having a more intrusive, breaking down a door for a wellness check. This information can be put in by family members or people in the home. Of course, the DAC and other local resources. Is there somebody? Oh, I'm seeing a chat. Oh, I thought I heard somebody maybe chiming in. So our next steps in 2025 will be again continuing our interviews with community stakeholders, partnering with other organizations to finalize packet inclusion, doing translations into different languages and making sure that it's appropriately culturally adapted, and then disseminating these materials and getting appropriate feedback as well. So a brief overview of 2025. I guess we're done with the first quarter. So really hoping for feedback from all of you. And thinking ahead to not just the safety packet, but how best should we disseminate this information and also have it available going forward? How can we make it best accessible to everyone? So some questions I have are, would the safety packet, would it be useful to your practice? And also, do you have any of you heard about Smart 911 and languages? So I'm hoping to hear from, get input. I'm trying to get my video.
Outstanding. Thank you, Dr. Domoto-Reilly. Yeah,
I have more questions,
we
but
do. Oh,
this is to start with.
ask away.
No, there's more. I'm saying there's more. There'll be more questions on next slide, but I thought this was enough for now.
Yeah.
Lynn put a question in the chat. She said, I have not heard of Smart 911 before. How widely used is it?
And Sammy, you've been chatting with these folks.
Yeah, so Smart 911 is currently located in Clark, King, Snohomish, and Thurston counties in Washington state. We have worked with them and spoken with them directly to get their permission to be utilizing their information on things like this trifold. So I have a little bit of additional information. They, of course, recommend that anyone can make a Smart 911 profile, because if you go through one of those counties, or if your loved one might be found in one of those counties, it would still be useful information, even if your particular dispatcher does not use Smart 911. They are working with DSHS to think about expansion in the state, but I do not have any additional information in that regard. The other thing that they did want to communicate is that for our purposes, for dementia crises, it is extremely useful because you can list information like medication someone is on, their diagnoses, and other information about that person that might be very useful in locating them generally, such as where they like to go. But it is also useful for things like fire emergencies, and things like that. So Jamie just mentioned in the comments that she interacted with fire personnel at the Northwest Rural Health Conference who said they didn't have access to Smart 911. I will say that knowledge of Smart 911 in our experience was very siloed within the actual 911, like the 911 locations where they were answering and using the call centers, because when we discussed it with law enforcement, they also were not aware that they had this in their community. So I think it's something that is very well known by dispatchers, but may not necessarily be as well known among first responders, because the first responders get the information, but they don't know where the dispatcher gets that. They aren't positive if the dispatcher gets that on a call history, or Smart 911. None of that is separated out when they're delivering it. Does it link specifically to the EMS/first responder system? It links, it's a pop-up that links within the 911 call center. So I don't believe that the EMS or the fire or the police actually see what you put in Smart 911 necessarily. I think that is communicated to them by the dispatcher. I don't know. I have not spoken as much with, we haven't spoken very much with fire. So I'm not sure if that's different for them because Smart 911 does have things like house layout that would be useful for them to be able to see and information about pets, but I'm not sure if there's a way for them to access it on their side. And please let me know if I didn't answer any of the questions about that. I know Lynn also asked how widely is it used. I think that 911 operators are very aware of it. I think that the Smart 911 people I spoke to are looking for, are hopeful for wider adoption because they think it is a useful tool.
Yeah, it sounded like in the Tumwater area, there had been a few years ago, they had done a big, community outreach and made people aware, but it's been a few years since they have done that. And there was interest both in Tumwater and Washougal that, they could host sessions, for example, at the local library to help people who don't always get online to help them sign up.
So it's just, I guess I'm still trying to get my head around this. So it's county specific, or if it's not one of those 4 counties you mentioned, it can't really be useful, right? A county has to buy into it somehow?
Yeah, I think that the counties, the 911 systems in those counties have purchased a package so then they can see the information.
Got it.
I don't know if it's available in counties where you have not purchased into it. I don't know if they would be prompted or not, but my understanding is that like that's how you gain access to the system is through purchasing a package with them.
Thank you. Yeah, I live in Tumwater. I've never heard of it. So I'm I'm curious. Yeah, I'm very interested. So yeah, thank you.
Carol.
Yeah, I was just looking at their website. I've never heard of it either. Lynn, it's Carol. It looks like, looks to me like it was, it's a private company that sells a product to local communities. So it looks to me like, because there's a big, buy our product, download our app. Like, it sounds like some communities in the state have made that purchase. But of course, that creates some uncertainty around, is this the only vendor? Are there 12 vendors that look like this?
Right.
Slightly different names? Are they going to pay for it again next year? What about when they go out of business? So just kind of all those questions, I think.
Yes, yeah, and we were asking those questions too, and yeah, each county sort of makes their own decision about which vendor to use, but of course, yeah, once you're locked in, there's an interest in continuing to renew, and it was what we also wanted to know was like, well, how is this paid for? And it did seem like it was very helpful to the dispatchers to have this because it's external. That company is then responsible for maintaining it. And the information is, they think of it as being very secure because the information is only available during the call. And some places they were actually paying for it, like you get your cell phone bill and there's the extra taxes. So that's how they pay for it is through the cell phone, a little extra local cell phone taxes.
Oh, interesting.
So yeah, so I feel like as clinicians, we often worry also about protected information and who would be putting this information in and who would have access to it. And so didn't know if folks had thoughts about that. One thing about Smart 911 is that there's like every 6 months or so, the person who put in the information is queued, like, is this still relevant? Is this information updated? And again, that was another piece that the dispatchers felt was very helpful, was that the onus is placed on the community member to either keep the information updated or it's, I think, it may be expunged. I actually do not know. So in terms of, Lynn, like you're saying, I think anybody can put the information in on behalf of an address.
And you might have mentioned this, but I believe I also heard them say that the information is only accessible when there's an active call. Otherwise, there's no way to access it.
Exactly.
Right.
And there's also the caution that not all the information that is put in there, it may not be relevant to the call that happens.
And I will say it's also linked to your cell phone number. So if you call from like a cell phone, that it will pull up automatically if you have a Smart 911 profile associated with that cell phone number. And in the interest of disclosure, so Smart 911 is owned by Rave, which is owned by Motorola. So there is a link to the cell phone there.
I had a question, Kimmy. I do sometimes get the question from family members, should I go down to my local police department and tell them that my loved one has dementia? And I thought you mentioned that. So is that just sort of like, even when there's nothing wrong, they can just walk down there and say, hey, be aware, and that's put down, and that the police department actually welcomes people to do that, so they have that information?
Yeah, yeah. And that was, sort of what, in some ways for me, as a clinician, I'm like, is that a helpful thing? But it's not, at least these two police departments welcome that. They want to know their community members. And then I think they also would like, and I guess that's our next question for all of you, is if somebody who maybe they haven't made it into the clinic yet, but they're worried about some caring for someone with memory loss. And so they go down to the police department. Would this be an appropriate packet to have on hand for them? Because they want to connect them. They say, we hope you never need us. We hope that 911 is never called, but they want to be able to provide their community with appropriate alternatives.
I always do coaching with the families that I work with when they call 911 to always frame it as a dementia crisis, especially for those situations where there's behavioral or threatening behavior. Um, so I don't know if there's that sort of, you know, coaching that it's helpful for everybody to start that way with saying, like, this is a dementia kind of a medical situation.
Yeah, and that actually, I think that was a very hopeful thing, that everybody we talked to knew what dementia was. I mean, I guess maybe that was very heartening to me, that there's been enough education that if the word dementia was used, I said, yeah, we know that there's different types and stuff, but that the use of that word, everybody that we'll be sensitive. So that was from people, just out of the academy to very experienced members. So they did want that information. And then there was also, they, as part of the dispatcher protocol, they are supposed to ask, do you need medical assistance? But there's also, if you start with I need medical assistance, that also shifts them to a different protocol. So the advice there as well.
Yeah, that's really helpful because I kind of, in my mind, I kind of imagine for the 911 dispatch people that if they just hear that there's violence, it might be sort of stuck on that domestic violence track. So kind of just clarifying that dementia piece so it doesn't go down the wrong track of the way that people are thinking about it. That's helpful.
So it would be great if folks wanted to let us know, like, if we develop this safety packet, would having these trifolds available in your clinic, would that be something useful or not? Please tell us either way. Is this something that would be, maybe you already have something you give to people? Would this be a useful thing in your practice? I know also, we at Memory and Brain, we're very fortunate to have Karen, a full-time social worker who often fields these calls, not the clinicians. And I'm also wondering if other clinics, are there different routes people take curious to hear about that as well.
I'm happy to speak for the geriatric clinic at Swedish. Just that I think for us and within the family medicine residency clinics, this is mostly duplicative of information that we are already sharing around Alzheimer's Association and the DAC. Being, sources of information for our patients that are sort of already in our smart phrases and after visit summaries and things like that. So I'm not sure how much it would change kind of what we're doing. The Smart 911 thing would be new because reference previous discussion. I guess it makes me question a little bit, and I'd love to hear your thoughts. Like what would you say the goal of the pamphlet is? Are we trying to prevent 911 calls? Are we trying to make them more effective when they happen? Or are we trying to, when one happens, have something to give to have the outcome of the call be different? I'm just wondering what your research has led you to believe is the improvement that we need to see.
Yeah, unfortunately, ideally, it was to never have the 911 call happen. And so I think that is, maybe also as clinicians, it sometimes can be tricky in terms of when do you bring up this information? Sometimes at initial diagnosis, to begin to go down a catastrophic thoughts sort of thing is maybe not, that might be too much versus you have it slipped into a packet for people to look at. Another thought was, to have more information out in the community so that people do not have to come into clinic to have this information at the ready, because sometimes it's also a concerned neighbor who places the call. It's not the person providing the direct caregiving and has all this information. Is somebody else becoming concerned? I see this person wandering around. How can I help? Well, I guess I'll call 911. I don't know who else to call. Definitely law enforcement was, again, hoping that they're saying, we like to help, but we are usually not the best people to help. We are here for safety. We will always respond, but probably ultimately it's not our help that you need. And so that was a lot of feedback from them that again, getting the word out into the community, what are other resources, how to reduce the risk sooner. And to also empower sort of indirect caregivers, our community caregivers, people who are looking out for their neighbors, wanting to help, but not knowing how to.
I mean, I think if that's the goal, then maybe thinking about, is there a little more direct language in the pamphlet around, like, instead of 911, how about this? Or just kind of thinking about the avoidance, that may not be the best resource, but there are some other resources in here, they are. Because I do think that's an important sort of teaching point to get out into the community through clinical settings as well as other settings. And that's not something we typically tell our patients, I don't think.
Karen, it seemed like you might have had some thoughts related to when
Yeah,
to call
I do think,
911.
one of the things about having a brochure in clinics is that, I think it's true in a lot of diagnosis, but especially dementia, where the care partner doesn't feel comfortable talking about safety concerns in front of their loved one. And so it might not come up as a safety concern with the providers, but if they could see, like, there's a packet, like, "Ooh, preparing for dementia crisis," could be really helpful in that regard. Um, so I like that idea, even in clinics like ours where we talk about dementia resources all the time, to kind of saying, like, preparing for a safety crisis. That seems helpful. I also think about, when it comes to things like wandering behavior, I think that the recommendation is that if your loved one goes missing, you should actually call 911 almost right away rather than spending a lot of time looking for your loved one, because the longer you wait, the harder it is to find them. So I also think that's another reason to call 911 and for everybody to have realistic expectations about what that looks like. And then I do think too, one other thing too is that sort of like questions about what do I do with my loved one who is having a behavioral crisis? And like, how do I get them out of the home? How do I get them to safety? Is just such a prominent issue for family members that are supporting somebody with dementia. And so sort of knowing like, there is that balance between autonomy, kind of that realistic expectation about what the help would be. I think this is really important information.
And so Carol, it sounds like you already have a smart phrase for some of these issues that you put like in an after visit summary.
Yes, although that's not to say that it, I'm just talking about like our clinic at Swedish, which does this a lot. I think probably broader SMG, for instance, very likely they don't, and it would be very useful, I think, in those, general primary care settings.
And do most people feel like, paper is still very helpful? We're hoping to have this available going forward, but if there's a place where people can print it themselves, like again, what media would be helpful, or how are you distributing this information currently? Is it, again, handing it to people, or you have pamphlets up that they grab?
On that question, we actually put out a brief survey to people who were attending the Dementia Innovation Summit last month and asked the question of how do you want to be informed and what kind of medium do you want it in? And I'd be happy to share those results with you. We had like 20-ish people respond. But by and large, they wanted it in a digital format that they can either put into a summary note or have it in a digital format so that they can download it and print it as needed.
Great.
But I would be happy to share this with you.
Great. Thank you so much. Yeah, and it was interesting to learn that also officers in their car have printers that they can print things off as well. And that they did feeling like having something tangible, at least the communities that they serve directly, that it was really having something, a small bit of information would be the most helpful.
I would agree that like trying to keep like a printed trifold brochure like in stock and where is it and I need it right now is not that great. Whereas something that you know where to go to print something out on demand is better. And that's going to work better as like a one pager rather than a trifold, because like it's hard to print a trifold on demand because it doesn't sort of fold correctly and you don't really know exactly how I'm supposed to print it. And so I would advocate for a one pager PDF that is on a website somewhere that can be printed on demand.
Maybe there could be like a QR code on, when I think about our clinic, how we have materials posted, they have some of those, like, are you concerned about safety? To link to like a PDR, like a flyer or something like that.
And the reality for primary care, like this is going to be great for like a memory clinic. It's going to be great for a geriatrics clinic, but like your typical primary care clinic, there's so many materials that cover such an enormous range of things that this isn't really something that's probably going to like rise to the level of like, being in a waiting room or even, it's like, I guess if you are lucky enough to have a social worker working in your primary care clinic, which very few clinics do, it would be like in the files that a social worker would keep. But otherwise, like the general primary care practice is just like not going to really have like the bandwidth to keep something like this on file. It's just not going to come up often enough. Or, I mean, it's just going to be like one of 500 sort of resources that would be available.
Yeah, and Sammy and Jamie are sort of putting comments in the chat that you know, to make it a bit manageable, we started with, okay, people with a diagnosis seen in a memory clinic, but you know, law enforcement is interacting with all sorts of public, and so could again this be a way to just help have the information available, you know, as people are waiting to get into memory care, just getting the word out. And I guess along those lines, another question was languages, certain languages that could be helpful. I mean, we know we'll have to be very sensitive to who feels comfortable interacting with law enforcement. But are there certain languages that you would say, you know, these need to be translated into? Sometimes that maybe can be the most helpful, is having something in a different language in writing, because somewhat, you know, our after visit summary, sometimes it's hard to get it translated appropriately. So are there gaps there that anybody feels would be particularly important to address?
A little bit of a tricky question in terms of certain groups maybe not being super comfortable interfacing with law enforcement. Thinking carefully about that.
Yeah, and sort of along those lines, Kimmy, I'm wondering and thinking about how you might partner also with, you know, senior centers or faith-based communities or other community organizations where seniors are doing their thing and might know of somebody who, you know, may be vulnerable to a dementia crisis. Because I could see there a one page or even a trifold that somebody might take and then look at, and it would be helpful in that context, potentially, I think.
You know, I think one of the issues, because I got a phone call recently from somebody in the Olympia area. Well, it was probably 6 months ago. And her husband had been picked up by the police and literally taken to jail. And there really wasn't a lot at that point that I could do for her. You know, I mean, it's so community specific around who's going to do what around that kind of legal situation. And so I have been thinking about this in terms of it's very local, depending on who people trust. You know, different communities have different aspects to their law enforcement and their EMS, and like the rural communities, man, they rely on their EMS people for a lot of stuff. So I think it's community by community. It can be really different. So I don't know. I guess as I've been listening to this discussion, this reminds me of, like, we were talking about this 4 years ago. And so I am really heartened, Kimi, that you say that they seem to understand dementia, because that was one of the first things that we started talking about around this, was that there needed to be more education on dementia. So at least I'm glad that has started to happen. And I don't know if it's just that community or if that's broader, but there is this thing where they get their training. And I wonder if this came up at all in what you were doing. It's called EMS Connect, where they get a lot of their training. It's sort of this online system that people buy into in the EMS field. It just made me wonder if there is some way to be connecting your resource that you're thinking about into a training like that. So, you know, like they get a training and then they get this resource that they can use that might be considered trusted from that resource. We got sort of blocked going into that just because it's a private company, again, that does continuing education, this EMS Connect. So it's just something you guys might want to think about, because if it were tied directly into a training, I think it might get some traction as a sort of tool or a brochure to use or something. But then it would have to probably be more general and not specific to a local area. So you just have to think about that. Like, do you have to adapt it for a certain community, or can it be general enough?
Yeah, thank you so much. Yeah, that's where we're thinking, well, if you have extra, like, I mean, my gosh, Snohomish County, what a resource. Making sure, and that was the beauty of this Garvey funding, is really focused on Washington State, and realize, yeah, I mean, Seattle versus Spokane, just different, there's different resources, and how can we highlight resources that have been successful, and get it into the appropriate hands. Yeah.
And Lynn, to your point about being community specific, we also heard that it's officer specific, that there are some that are very well versed and will respond, in a careful way, and then others that are just like, you know what, we're going to solve the issue at hand and we'll deal with it later. So there's still needs within these departments,
Yeah.
across departments. So the work
Yeah,
is
and
done.
I feel like, and I think probably everyone's like, how do we, what's the next step? So having that, okay, I can give a pamphlet. There was a lot of interest in how do we help someone, but yeah, I think that's partly why we want to finesse the pamphlet. And yeah, Sammy is bringing up that of course we were invited in by Tumwater and Washougal. They were wonderful partners. And so part of this is hoping that word gets out. We're not here to, because it does seem like, dementia has been heard. But if we can get some, word of mouth, partnerships going on, that might go a long way. I mean, what was something that we also heard about from some of the other community organizations was, yeah, we'd love to work more with the police, like come to our support group. If we hear from the police that this community should sign up for Smart 911, then we can facilitate that. But more of the direct communication is appreciated. And so, yeah, we can't say enough how thankful we are to Tumwater and Washougal. And we do hope that helps us reach other communities as well. And yeah, the fire is just as responsive. There's so many different ways when people need help to access this information. And then the other thought too was, for example, with Smart 911, although that may not be the end all be all, but for caregivers outside the state, for somebody who's further away, again, how can they help make the community aware of potentially special needs, just to reassure caregivers who may not be immediately on scene.
Kimmy, one of the other things I saw in your data that on the slides was that a lot of calls came from adult family homes, and just acknowledging like that's sort of a different pathway than the let's educate the caregivers that are living in the homes, and that's probably more of a protect our staff protocol driven. I don't know, just in my experience.
Yeah, I feel like that's
Well,
come up.
you don't educate paid adult family home caregivers in the same way that you educate family caregivers in the home setting. So maybe easier, maybe harder, but if a big percentage of calls are coming from there, it might be a slightly different intervention possibility.
Yeah, and I feel like that's been a theme of other ECHO discussions we've had. Yeah, absolutely. And that, to make sure everybody feels safe and heard. And again, where do I go when I need help? Thank you, Carol. Very important.
I know Lynn mentioned the move for some additional training around dementia specifically and maybe making it wider. I know that this is good to know. The training for autism is pretty minimal, but I do know that some of the newer law enforcement officers that we had mentioned that they had gotten autism specific training in their law enforcement education and things like that. So there is a precedent for having training around specific conditions and how that could interact with law enforcement.
This has been really helpful. Thank you guys for sharing it.
We have about 10 minutes. Did you want to turn to some vignettes, Kimmy, or do you have other questions that you wanted to ask?
No, thank you everybody for answering my questions. I guess, yeah, is there anything that we're missing? Or anything that you, as we circle back to law enforcement, continue to work with community members, other feedback or questions that are important for us to know?
The other thing I'll share as you're maybe thinking about that is yesterday at the Indian Country Dementia Echo, one of the geriatricians from OHSU did a fantastic presentation on firearms in dementia. And I don't know if that's of interest for our community, but I would be happy to reach out to her, Robin Brown, Dr. Brown. Really well done and very pragmatic and relevant to our last couple of didactics on this topic. So if that's of interest, I'd be happy to contact her. It's a thorny issue. Also intertwined with constitutional rights.
And in that vein, if there are any practice issues that you have that you think would be helpful, that questions that you have that you want us to bring to law enforcement partners or community partners, or if there are things that haven't come up that you think that we need to address, we are also very open to hearing about those as well.
Well, let's do this. We can kind of wrap up with some closing information. Reshare my screen. All right, so again, cases, always helpful and appreciated. Just a reminder for any UW affiliates, here's again the process for claiming CME. We have solidified some additional didactics. So next time I will be doing a didactic on cognitive screening, particularly with a focus on sensory impairments. And then Dr. Eisenberg, Dr. Tam with Women's Risk and Resilience for Heart Disease and Dementia. We have our own Dr. Russo for our community doing a DLB and cyclinopathy CME, psychiatric medications from our fellow here at the University of Washington, Dr. Jimenez, and then our own Dr. Heyman on the 27th. So fantastic to see community members presenting as well, not just cases, but the didactics. So look forward to that. We're also very close to announcing the rest of the year's didactics, so stay tuned for those. And then also stay tuned for that 1-minute post-session survey. We're going to give you back 4 minutes now, so you'll have 3 if you do the post-session survey, and we'll stop with that. So thank you all, and thank you again, Dr. Domoto-Reilly, for such an excellent presentation, and also just being passionate about doing this work. It's so important, and we've heard that from all sides of the equation. So thank you for your initiative in pulling this together.